especially with that more fibrotic chronic clot, is an ongoing issue. And so there raises the question of a dual action mechanism. So a moderate bore thrombectomy device that does offer advanced solutions for that more chronic clot. So enter the Helo PE thrombectomy system. This is a 15.5 French catheter with a 24 French atraumatic funnel at the end. There's some compound bends in the catheter that you can control through the device, which is this roller ball here. And it has dual action. So there's a high-speed agitator as well as controlled aspiration by the physician using this button. There's a diagnostic port for those of us that like doing continuous pressure monitoring. You can hook it up to the continuous pressure, or you can use this for intermittent angiography. This is just a video of how the device works. We'll walk you through it. This is the dilator that's used to pass over the wire. The wire and dilator are removed. Funnel is introduced. Through the catheter, you can pass the agitator, which stays within the funnel. And then using that wheel, or actually the catheter itself, you can do multi-directional. You want to be on fast with the clot, and then you're going to activate that aspiration as well as the agitation, which is going to kind of help invaginate that clot into the catheter for removal. So the ENGULF trial design was a two-phase prospective single-arm study. It's to assess the safety and feasibility as well as efficacy of the system. The feasibility phase is complete, which was 25 patients, and the pivotal IDE phase is ongoing, the goal of 100 patients being enrolled. The primary safety endpoints are device-related major adverse events at 48 hours, which would be all-cause mortality and VARC2 major bleeding. Device-related serious adverse events, which would be clinical deterioration, pulmonary vascular injury, or cardiac injury. For efficacy endpoints, primary was RV-LV ratio on CTA from baseline to a 48-hour post-procedure CTA, which obviously is not typical for clinical practice, but certainly for the sake of the trial. Secondary endpoint, reduction in modified Miller scores determined by a CTA core lab, and then a reduction in targeted clot volume as determined by a separate angiographic core lab. Again, these were independent core labs. CTAs, again, at baseline and 48 hours assessed. And then for those that had pre-angiography images, that pair of pre and post angiography was sent for independent evaluation. Baseline characteristics in this patient population, the mean age was 66, with 64% being male. Predominant white race, BMI of 31, and around 16% having DVT, with 12% having PE or COPD. Baseline systolic blood pressure was 130, heart rate 91. 100% were greater than 90% SpO2, however, this is with supplemental oxygen. Creatinine 1.1, 71% having elevated troponin and a BNP, slightly more with just single elevation in troponin or BNP. And then baseline RV-LV ratio of 1.53. From a procedural standpoint, the baseline pulmonary artery systolic pressure was 50, with a reduction down to 43.1 post-procedure, and mean procedure time was less than an hour at 57 minutes. Blood loss averaging around 345 cc's. Length of hospital stay for patients was 4.2 days, and post-procedural escalation to intensive care was 4%, which is one patient. For our safety endpoints, our primary endpoints, there were no device-related deaths within 48 hours and no major bleeding. There were 2 patients that required transfusion post-procedurally, which was therefore definition of a device-related serious adverse event within 48 hours. No pulmonary vascular injury and no cardiac injury. Secondary endpoints, there was no additional clinical deterioration at 48 hours and no deaths within 30 days for all-cause mortality. No additional device-related serious adverse events, and no PEs within 30 days. The mean reduction in RV-LV ratio was from 1.53 to 1.15, which correlated to a 23.2% reduction. For secondary efficacy endpoint using the core lab, there was a 16.5% reduction in modified Miller score and an 83.8% reduction in thrombus burden using those pulmonary arteriographies, which was about half the feasibility cohort at 12 patients. Just to go through a case, this was a 65-year-old that developed sudden onset chest pain radiating to the back, had left arm and jaw pain, and was 10 days post ankle fracture. had some ST depressions, was on a non-rebreather. You can see on this CTA had proximal clot in both the right and left main PAs, extending into the upper lobe and inner lobar. We can see on this right side pulmonary arteriogram that we have some clot right at that junction of the upper lobe and the inner lobar artery. And then post-thrombectomy, we have some excellent clearance here, and I have some stills here to show that. And then on the left side, on the pigtail flush run in the beginning, you can see some pretty significant clot there on the left main, and then post-aspiration on the left, we have a reduction in that clot burden. So in conclusion, this was a multi-center feasibility study of 25 patients. The Helo-PE thrombectomy system did reduce the RV-LV ratio by 23.2% without major procedural or 30-day complications. And both CTA and angiographic core labs showed a reduction in clot burden. And we are looking forward to the prospective IDE data that's coming out, and the pivotal trial is almost complete. Thank you.
Thank you very much. Can you stay back for a few minutes? We got 3 minutes for discussion here. Congrats on the completion of the feasibility study. I'll start with the blood loss that you showed. Seems slightly, out of the ordinary. Can you tell us more about that? Is it a device thing? Is it a patient selection thing? What happened there?
Well, I would argue it's not out of the ordinary. 350 cc's of blood loss is, when using an aspiration that doesn't have a blood return system, is not unusual. I think for people that do this frequently, most of us probably would not transfuse as a result of that level of blood loss. Any new device that's out there has a learning curve. And actually, 57 minutes of procedure time is quite low, and we're seeing in our prelim data that's already decreasing significantly with just utilization of it, which I would expect, same thing, to go with blood loss. I think as you get used to the aspiration of a catheter and how it maneuvers and manipulates, that number would go down.
Any questions from the panel?
Maybe I'll ask one question. How does this device change your workflow compared to other technology out there right now? Is there anything unique that is different than what you're using compared to commercially available devices? Or?
Yeah, absolutely. So the catheter itself is highly maneuverable. That double angle curve on it and its flexibility, the fact that it's a 15.5 French device and has a larger funnel at the end, you're able to do all your manipulations without a wire and catheter. So once you're into the pulmonary system, you can go from right to left as needed without having to use any wire and catheter selection. Makes the procedure time a lot quicker. Also, certainly the agitator is a novel element which helps invaginate that clot during aspiration.
Thank you, and congratulations. This is a really interesting set of trials. Would you perhaps just elaborate for your inclusion criteria? How old could these clots be in terms of symptom onset?
So it's based on symptom, obviously. I think if we can figure out, if we know how old a clot is, that would be excellent. But based on symptoms, less than 2 weeks.
Last question. Are the endpoints pretty much identical for the IDE trial, or are you looking at something else, or modified Miller score and the RV-LV?
Yeah, we'll still be looking at those, just a larger patient population, obviously, and there's a generation 2 catheter. The company's been excellent. It's already innovated a second generation, and so having that, which is an increased curve, essentially, which increases that manipulation, that will be included in the pivotal trial.
Great. Thank you so much.
Thank you.
Okay, we'll next bring Dr. Manch Goel. He is going to talk about the Spectrum trial secondary outcomes. This is the comparison of cyanoacrylate to surgical stripping.
Great, thank you very much. Good morning, ladies and gentlemen. I'd like to thank the Viva board for this opportunity. This work is very much presented on behalf of the investigators and the teams that were recruiting these patients. So the first question is, why are we doing a trial comparing endovenous treatment with surgical stripping? I mean, surgical stripping is largely obsolete in the US and in the UK. The reality is, in much of the rest of the world, surgical stripping remains a dominant treatment, not only in low and middle income countries, but also large parts of Europe. So in Germany, for example, surgical stripping is the dominant treatment. The second reason for looking at this is that actually large randomized trials that have previously looked at stripping, for example, the Klaus trial, did not demonstrate a big difference between endovenous ablation and surgical stripping. And so I think it's important when we are looking at new technologies that we compare against the global gold standards.